So before we start any podcast, we like to ask some quick fire questions, and this always sets the scene and gives you the insight into your level of work. So the first question for yourself today, Tracy. So based on your experience and work in the negligence field, which specialty of medicine gets the most negligent claims?
Well, I would say, I would guess before I looked, obstetrics, so birth injuries.
Yeah.
But then I did actually look at the NHS resolution figures, and the top three are emergency medicine.
Okay.
I guess not that surprise. Obstetrics, so yeah, it was not far off, and orthopedics.
Oh, wow. Okay. I would have guessed radiology, maybe people missing things on scans, but okay, that's very interesting. Second quick question is, what's the single most common documentation mistake, if there is one, that leads to a reasonable case being presented?
I would say failures to document, just generally, not documenting enough, not writing enough things down.
Fine. So that's a very, very important one. So you can say true or false, or fact or fiction, or fact or myth. Patients are just interested in taking clinicians to court to get big payouts. Is that your general feeling, or do they want to explore the case?
I would say myth completely. I think patients, if they're injured, have got a right to get compensation for that. And I think you have to consider, if you were by a car, would you claim on their insurance for injury sustained? Well, I would imagine most people would. Yeah. So why is the NHS any different?
I think that's a very reasonable point of view. Okay. So what are the general motivations for patients to seek a negligence claim?
Obviously injury, so they want compensation for the injury sustained. But I think a big factor involved is how they've been treated, how communication's been made with them. Things like medical gaslighting, not taking on what somebody's saying. I think that makes a big contributing factor to whether somebody will pursue an issue or not.
I think communication is such a big one, how you discuss with the patients as well. So that's really good. And final question, who gets believed more in the negligent claim system? Is it the patient or is it the clinician supposedly at fault?
I think whoever seems to be more reliable source of information. So probably the clinician, but the notes have got to reflect, they've got to be accurate. So if that's not there, then the courts may fall on the side of the patient.
Fine. Thank you so much. Hi guys, and welcome back to the Pareto Podcast. My name is Camille and I'm your host. The Pareto Podcast aims to bring in many illustrious guests who can share their valuable experience working in and around the NHS. You get insights into their career path, any advice and tips as well. Who's an experienced physiotherapist and has pivoted her career into working in the legal side within the NHS, working in the peripheries, supporting clinicians, but also providing her analysis on case reports, legal cases, and also helping key witnesses. And she also deals with expert witnesses who provide a wealth of knowledge and provide backing for certain NHS cases. So I'd like to introduce you to the lady of the hour, Tracy Fields.
Thank you.
So thanks for joining us today.
You're welcome.
Got quite a lot to cover.
Yes.
Hopefully you're ready with some prep. I can see it in front of you, and hopefully we can have an insightful discussion and we can share some of those insights with our audience as well. And from our perspective, I think it will be beneficial in two ways. One, from an insider's look of how legal cases come about, things like negligence, when things go wrong, and how to protect ourselves. And the other side, I suppose, is if anyone's perhaps interested in the audience of how to pursue a similar career, any advice that you can offer them. So I think they're the main two themes of this discussion. All right. I'm sure I gave you that introduction, but if you want to introduce yourself in a few sentences about yourself, your academic background, and the kind of work that you're doing at the minute as well.
Okay, so I'm an independent physio now. I qualified over 30 years ago, worked in the NHS for a long time. Worked in district general hospitals, a big teaching hospital, and then latterly at Sheffield Children's Hospital. So I was there for 21 years, worked as a clinical specialist in limb reconstruction for all that time, managed quite a big team across orthopedics, burns, plastics, and limb reconstruction. So physios, OTs, rehab assistants. And then about 11, 12 years ago, I had the opportunity to start some work as an expert witness. So because I was an expert in my field, I was asked to do that. And that progressed. So I've carried on doing that all this time. In between that, I've done a little bit of work as a case manager. I'm currently working as a case manager, which adds a different layer to my expert reports. It gives me a better understanding of how litigation works. I'm still working as a private physio because you need to be practicing to be an expert witness, really. And then I do other bits and bobs. So I'm a moving and handling trainer. I do some training. So I do litigation training, defensibility, how to defend your writing, that sort of thing in the NHS.
So it looks like you've had, a varied career during your time working within the NHS. And, some of the more interesting things I think you've developed in terms of your passions, in terms of what kind of areas you want to explore. That is things like training and things like showcasing how to better protect yourself in today's climate. So I think that's one of the things that generally people, I'm talking about professionals in any capacity that work within such a big organization such as the NHS, and we're so heavy on, documentation. I always make the joke that before I worked in the NHS, I used to write things down and now I document. It's one of those things where, really pushed hard on clinicians, no matter what capacity you're working in. So these kind of things, you help people improve, would you say?
Yes, yeah.
And as part of your work, do you see poor examples as well as good examples?
Oh, absolutely. The majority of the cases that I would see through litigation are generally poor examples of documentation.
So, from our perspective, I work still in the NHS. There must be a process that a patient goes through to get to eventually see someone as yourself and, you providing your insight into the case. I suppose the first step is when a patient perhaps is unhappy. They complain to the ward manager, they go through health service, patient liaison service. And then at what point does someone like yourself get involved? And one time, does a case start building?
Okay, so they may go through those processes, but they may not.
Okay.
So there may be the first time you hear of anything, maybe a solicitor's letter on your doorstep saying somebody's taking legal action against you. But people do. So it could be that something's happened. So they go to PALS. They may go to your governing bodies to complain. So for us, HPCP, so that it might come in through that. And then what will happen is if they meet all the criteria for a legal claim, which I'm sure we can talk about later, they usually go and find a solicitor. Then the solicitor will investigate further. So you may then get a letter saying, can we have their records? So the medical records will be requested and then they'll be reviewed to see what harm's been done, when it happened, if the treatment that they got was appropriate, if it fell below a standard that's acceptable. And then at that point, it may be that somebody like myself, an expert witness, has a look at that and advises the solicitor whether there was a breach of duty or not. So for me, you tend to stay in your profession. So if it's something that's concerning a physio, then I would be asked to look at the records. If it was a GP, that sort of thing. Sometimes there's a little bit of crossover. So I'm working on a case at the minute that the prime focus at the minute is a physio, but on the sidelines there's a potential issue that happened with the GP. So sometimes I might be asked to just have a quick look and see what the GP did. But obviously that's not my area. I can't really comment on a GP practice. So that's where I would get involved if I'm looking at liability. So sometimes we bypass that. Sometimes as a physio, there's no need for a physio involved in that liability stage, and it may be much later on when we're looking at quantum. So quantum is where you quantify the value of the claim and basically how much compensation is going to be awarded to this person. So there's 2 points where the physio may get involved.
Okay.
And obviously that'd be the same for every expert relevant to the case.
Fine. So it looks like there are a few different avenues that this can potentially come to you as a clinician. And generally, from your perspective, I don't know how well you know from the others part. So from the clinician's perspective and the care they've provided, how do they normally react and what is the normal situation from their perspective? Do you see that they engage with the process, or how does it normally progress?
So it's normally very detached. So I wouldn't particularly be involved with the clinician. It's just purely medical records that I get. And to be honest, there's no option but engaging with the process. So you may not have any conversation with the legal team at all, really. If you're working in a hospital, the hospital sued not the individual person, even though it's an individual person's actions in civil law and tort law.
Yeah.
So, and clinical negligence, obviously, if it's criminal law, then that's different.
Yeah.
So that would be the individual person.
Yeah.
That is different for GPs. So if a GP was sued, they would be sued personally and not the practice.
Fine.
So a GP may have more interaction with the legal team, but
Fine.
generally if a complaint comes in, say about a nurse or a physio and OT, then it comes into the trust. So the claim is against trust. So that individual person probably doesn't have any interaction with the legal team or much interaction. They may provide witness statements, but they don't really have a lot of interaction.
And based on, your cases that come towards you, what kind of evidence do you use to assess what's going on in front of you? Is it any interviews, or is it just purely based on the notes that are written in front of you and what you would do in that circumstance?
So a lot of it is that. It depends on the trust. So some trusts will do a case review. So if an incident was identified at the time, there may be an incident report. So that's always a good start. Then staff involved may be interviewed by the trust. They may get witness statements, and they're really helpful. So the clinician can say, actually, this scenario did happen, but it happened because of this, ABC. This is, we did this and this is the outcome. So they're usually really helpful. You don't always get those. So it may be that all I get, as in this case I'm working on at the minute, is the medical records. There may not be full medical records. Again, this case, there's not a lot of records, so it's very difficult to defend the clinician if I don't have any evidence in front of me. And that can be the only thing I get is a copy of the medical records.
Yeah, I mean, to me, that sounds a bit scary, because sometimes, you might only write a line or two on an interaction, or if something happens. I think it just shows just how important it is.
Yeah.
Based on any significant sort of event that happens, just to put your input in.
But I would also say not just necessarily the significant events, because it's all the events, but all the events leading up to the significant event may be completely valuable in building up the picture of that what's happened.
Yeah.
So I would say every single time you document anything clinically, you need to be thinking in the back of your mind, can somebody understand what I'm writing? Is this defendable? If push came to shove, can somebody look at them and understand what we've done, what we've found, what the differential diagnoses are, what we've considered, what the treatment or outcome is. So I think you just need to be really cautious of that. And I think in my experience, electronic records are far less in detail than handwritten records.
Okay, yeah, that was going to be my questions. What have you seen? We know notoriously that the handwriting isn't the best in the hospitals, even in primary care. But so what's your experience been? Have you worked kind of through the switchover with a lot of electronic patient records?
I still am, because a lot of cases can be historical, or, if it's pertaining to a child, I can get 16 years worth of records through. So the handwritten notes are very difficult to read sometimes, and it's very difficult to tell who's written them, because back in the day, people didn't write their registration number or didn't print their name. So that was very difficult. And a lot, if somebody's been seen at a lot of different hospitals, it doesn't always say on the handwritten records which hospital it's in. So trying to piece together is very difficult. So since the transition, it's better in that you can read what's being said, and usually it says who's inputted that data, so you get a good idea. It doesn't always say what grade that person is that's written. So sometimes, and that can make a big difference. I'm finding with the electronic records that they're often not checked. So, and typing's not easy for a lot of people. So there's a lot of typing errors, but a lot of people don't just submit it without checking. So sometimes it doesn't make sense. How they come off when I'm sent that data doesn't always make sense in how it's written. So it doesn't get printed off as I'm presuming it's put in. It's a bit, and there's a bit of repetition, but I would say they're much briefer than handwritten records, particularly GP records are much more, short. So in defending your practice, for example, say somebody comes in with a throat infection and you write strep throat antibiotics, that's not showing me that you've considered differential diagnosis, what the person came in with, what they presented with, what the obs were and things like that. Obviously, that's not a case that I would be looking at, because I don't comment on GP's practice to that extent, but it's that sort of just writing your outcome doesn't help yourself really defend what you did, how you assessed, how you came to that diagnosis.
And some of the cases you've mentioned are historic as well, so you may not actually remember.
No, and that's a big thing. So when if the trust does ask for a witness statement, very often the clinician will say, I don't remember that client, but from the records.
Yeah.
And then the problem is where it's not documented in the records. So the statement would be, often is, I don't remember them. I would have done this, so that because that's what you would do for this patient. But that's very difficult to defend because there's no evidence to suggest that you did on that occasion do what you would normally have done or what everybody else normally does.
So apart from clinicians having very brief notes, are there any other sort of pitfalls that sort of come again and again that you've seen in your work? Because it's a really interesting area that you're explaining, and I'm sure it's providing a lot of insight for our
I think
audience.
one of the big issues, it seems to be, when we're looking at litigation, is it very often it's not just a one-off incident. So very often it's a chain of events and there's lots of errors. And again, looking at GPs specifically, you know what it's like. If you go and see a GP, you'll see a different GP every time. Probably you get put in with whoever's got an appointment. So what can happen is that the errors made in the first appointment, for whatever reason, the medication that was prescribed perhaps wasn't ideal, didn't consider comorbidities. And because the next person that sees them has only got a few minutes to see them, nobody thinks necessarily that they need to review that the first medication was a correct medication, and it sort of snowballs. So lots of different people are seeing them. There's no continuity. Nobody picks up on these issues, and then things get progressively worse. So that is a common theme, that there's a lot of people. And that's why very often if cases are brought against GPs, you may be brought against multiple GPs in that practice because lots of different people have been involved.
I mean, I think you're absolutely right. We've recently done a teaching session on polypharmacy, and I suppose it's quite easy to start something, and once a colleague has initiated that, it's very difficult to argue, no, actually I disagree and I want to revert back to that decision. Or even such as for polypharmacy, take a medication off if you're not the person to actually have started that, to say, no, actually, I don't agree with that differential diagnosis. I think you have this instead. It can be quite difficult. And I think that's part of human nature as well. Once a decision's already been made, to sort of keep going. It's like box thinking, I suppose.
And I think things like analgesia, for example, something might have been completely relevant and necessary at the time, but nobody's sat down and necessarily had that conversation. Do you still have that pain? Do you still have the neurogenic pain? Do we still need things like gabapentin? I've got a patient that's been on gabapentin for 8 years. She doesn't have any radiating pain anymore. There's no neural symptoms now. So I did ask, well, so why are you taking it? Well, the doctor just keeps giving it me. So obviously that's not negligent. It's not causing any harm. It may be that if she reduced it, there would be neural pain. But it's that example of something that somebody thought was relevant or may or may not be relevant at the time, but nobody's questioned it because your patient may not have specifically come in to mention that. It may be something that's an offshoot of it. And because of limited appointment times, caseloads, all that, you may not have had opportunity to sit back and fresh pair of eyes and let's just review everything that's going on here, which happens. Everybody's busy. That's why it happens.
Yeah, it does. Yeah, absolutely. So a lot of clinicians are actually concerned about being sued. We see this across the spectrum from more junior staff to the really well experienced. So can you tell me some of the things that may lead to the context of someone being sued? And so what kind of things would be eligible for someone to bring a claim, and what kind of things can we do to protect ourselves?
Okay. So I think there is a lot of concern about litigation. I don't know whether that's a valid concern. I mean, obviously, there's always a risk of being sued, but whether the media plays a role in making people scared about it will happen because of all these people that are concerned about it. Have they been involved in litigation? Do they know people? Or is it just this sort of myth and legend that, oh my goodness? I also think that it's quite healthy to have a concern about being sued.
Yeah.
Because I think people that are blasé about it are the people that potentially will become unstuck.
Yeah.
And I think it's healthy as a clinician to question your practice and to write your records so that they're defendable.
Yeah.
So I do think that's a good thing. But there's a very, very big difference between people complaining and people suing. you will never stop people complaining. People complain, that's what we do. We're British, people complain. But just because you may have complaints about you doesn't mean you're going to get sued.
Yeah.
So to be sued, so there's three different sort of streams of litigation. There's tort law, so that's civil law. So that's when somebody is injured and they make a claim for compensation for that.
Yeah.
There's criminal law. So that's when something goes, so a clinical act goes beyond an accident, a mishap, negligence, so it becomes gross negligence. So that's when something is quite significantly beyond the realms of somebody just making an error. So for example, a lot of the big legal cases that, Harold Shipman, Lucy Letby, for example, that sort of thing. So they come into the media because there's a big criminal case against them. And there's also the coroner's court. So a coroner's court would not necessarily be something that there's medical negligence, but it can be an unexplained death and you may get called to give evidence. But for the purposes of this, we'll look at civil tort law. So for somebody to sue for an act of medical negligence through tort law, you've got to meet three criteria. So firstly, we've got to prove that there was a duty of care. So some areas, then that's quite straightforward. So if you go and have an appointment with a physio, you go to the physio appointment, you turn up, obviously there's a duty of care there, you've got that professional relationship. Some areas it's a little bit less obvious. So for example, if somebody rang up the GP practice and spoke to the receptionist and said, I really need an appointment urgently. And the receptionist asked them what was wrong with them and said, actually, you don't meet the criteria for an urgent appointment, so we don't have any. So that you've still got the duty of care. So your care starts at that point where somebody's deciding what's urgent, what's not urgent, what can wait. And sometimes...
Sorry, just to stop. Would that be on the receptionist, or would it be on you as a sort of a clinician in the practice, or is it in the protocol driven?
So probably protocol driven. So is your receptionist trained to make that choice, or have they just gone a bit rogue and have decided they're gonna, you're not getting an appointment today? Not that I'm suggesting that happens, but so usually it's protocol driven. Yeah. But your reception, if you're asking your reception staff to make that decision, so they're clinically screening your patients, there needs to be adequate training and adequate protocol or procedures in place that they're following that. So you need to, ultimately, the clinician needs, or the manager, whoever, needs to be confident that those making those decisions are adequately versed in it. So a lot of GP practices, for example, do the online screening now, don't they? Where you fill the form in on the internet, say what your condition is, and then somebody will prioritise the appointments. Yeah. So we've established that there is a duty. Yeah. So your duty is to your patients. It's not necessarily to your patients' relatives. So there's a recent-ish case where somebody had a psychotic episode and injured a member of the family. So the member of the family then tried to sue the people that were treating the mental health condition. And then it was found that no, they don't actually have a duty of care to that member of the family. Their duty of care is to the person with the mental health condition. So we need to clarify if we've got duty of care. Once we've established that there was a duty of care, it needs to be established that the duty of care was breached, so that the standard of treatment was not provided to an acceptable level, or somebody provided some treatment that was really not in the medical norm for something, really completely out there. No clinical evidence to suggest that works, but we'll do that anyway. Yeah. So we've got to know that you've breached your duty in some form. So that could be not seeing them, missing something, not referring on, not prescribing appropriate medication, or, prescribing something that was contraindicated. So that can be a vast amount of array of different things. And then once we've established that still doesn't mean that there's cause for litigation. So somebody can do something completely wrong and completely mess up, but if it doesn't cause harm, so the causation is not there, then that's really bad and a complaint is valid. But if they didn't cause harm, you can't take that any further in terms of litigation. Fine. If there is harm, so your patient's damaged in some way, and it's proven that is caused by this breach that happened earlier on, then so all three of those things in place, and that's when you can sue. Fine. So people can't just come in and say, I want weight loss jabs, and you say, well, no, actually we can't prescribe them because we're not in the area that prescribes them at the minute. And they say, right, I'm going to sue you then. They can't.
Okay.
So I think people have got this misconception that people can sue left, right, and centre, and they can't. Obviously, it's a completely valid concern, and and you need to be mindful of it. But I think the media seems to have whipped up a frenzy over litigation.
Yeah, and I think it's like these things, it makes good headlines.
Yes,
so,
absolutely.
These kind of things can be brought to national attention when the actual risk of it affecting you as an individual. And I think you made a really good point about, it should be, if you're a professional person working within the NHS in whatever capacity, not that it should affect your judgment, but you should be working in a professional capacity and think that, well, if I was to deviate from the professional standards or the norms or not provide the care that is expected, there is some recourse to that. Yeah. And like I say, certain people would never need that, but some people, perhaps that is a motivating factor in whatever capacity. So that's really, really interesting, and that you've showcased exactly what kind of things need to be fulfilled for a case to actually proceed. So can you, without going to too much identifiable information and breaching confidentiality, can you talk about some recent case that you were involved in, and what that was actually successful for the patient side, meaning an actual monetary or compensation package was involved?
So obviously I do a vast array of cases. I do a lot of cases pediatrics, so a lot of them are birth injuries. So obviously the cases, so something around 10% of children born with cerebral palsy are due to clinical negligence. So somebody has done something wrong that's caused that child to have cerebral palsy or significantly worsened their condition. So they may have had been mildly affected before, but they were significantly affected by clinical negligence. That's usually something to do with poor monitoring, poor reaction to the monitoring, that sort of thing. From a physio point of view, it's usually people that have failed to identify red flags. So they've usually missed something and consistently missed it. So you've been treating somebody a while, they've been getting worse, or they're showing neural signs that you've not really picked up on, and it could be something like spinal tumours, that sort of thing. DDHs are a big one, so missed DDH. So these kids often get referred to physio because they're a little bit slow for walking, so they might be referred for developmental delay. And it could well be that the hip's out of joint, and that's why the delayed walking, and they're often missed, hopefully not so much as they used to be, but they can be missed. And one of the reasons for that is they're often referred to the community physios that normally deal with the neurodevelopmental issues. So it's not on the top of their mind to think, I wonder if there's a DDH, I wonder if there's something structural going on, skeletal wise. So it's not really their sort of the focus of what they're looking at.
Just DDH for the...
developmental dysplasia of the hip. So you speak CDH back in the day. Yeah. So very often they'll be picked up at birth, but not all of them are, particularly if it's bilateral. So they're quite tricky to pick up. So there's some of them do get through the net despite the screening programs that are in place. The screening program is better than it used to be, but some still do get through. And very often these parents may have been to the GP to say they're concerned about how their kid is, that they're a bit slow for walking. So you've got your first contact with the GP that's not thought, I wonder if it's DDH. So they'll send them to the physio who may miss it. So again, this is where you get your catalogue of errors coming through. So they're quite common. Another really common one, sticking with the kids theme because that's really my area, is missed SUFIs, so slipped upper femoral epiphysis or slipped upper capital epiphysis, depending on what term you use. So I don't know if you're familiar with this condition. So basically it's a condition during skeletal growth, usually at teenagers, usually bigger kids, but not always. And the top of the femur slips a little bit on the femur. So that can happen really slowly. So it can be a chronic slip. So it happens really slowly over time, or it can be quick, or it can be quick on chronic. So it's been slipping slowly and then suddenly goes. So the slow ones can be quite difficult to pick up. So you often find that parents will take the kids to see the GP, and very often they don't complain of hip pain, they'll complain of knee pain or thigh pain. And because it's vague, they're often missed. I'm saying more often than not missed in that phase. what can happen is that eventually, it will slip acute on chronic and it all goes, horribly wrong and then it's quite significant surgery. So we've missed the opportunity to deal with that beforehand. So we're never going to stop the SUFI from happening. But if it had been identified and managed much earlier on, the surgery would be a lot quicker and the outcomes would be far better. So there's that sort of thing. And another example would be medication that's a bit more sort of GP specific. So a while back, I had a case with a lady that was prescribed an oral contraceptive and the GP didn't take into account her other comorbidities. She ended up, and this is another one that I saw lots of different GPs, so they just kept prescribing it. She ended up getting leg pain that was missed and she ended up with a clot and then ended up with an amputation. And there was a lot, in this case, an awful lot of opportunities that were missed along the line, again, because she saw a different GP each time. So obviously these are quite catastrophic injuries. I tend to do the catastrophic end. I don't do the mild end.
The legal cases and what precedes a legal case and what can actually constitute a legal case being brought against someone. In terms of, say the range of legal cases that you've seen that have gone through successfully through the system, what kind of compensation packages are we talking here? Like, does it just involve monetary elements? Is it given as a cash handout? What kind of things are involved?
All cases are different. It depends how old they are at the time. So say with a child that's been significantly, profoundly brain injured at birth, obviously that can take a long time to come through. But somebody that needs 24-hour care, maybe 2-to-1 care, you're looking in excess of £10 million for the compensation. They may get a lump sum during the litigation process to help meet their needs at that time. They may get another quite significant lump sum at the end, or they may get annual amounts towards the overall compensation, or it may be a combination of the two. So the big cases, primarily care. Care is the thing that bumps up the cost of a case, because obviously employing a care package is expensive. So your CP kids are, can be really quite high end, so over £10 million. And then obviously you've got to pay for the legal costs as well as part of it. So it is quite costly to the NHS. But obviously there's the minus side of the whiplash injuries, all that sort of stuff. I don't do that, and I do catastrophic injuries, so I'm with the 2 million plus really.
Really? Okay. And from your experience, how many of these cases actually go to actual what we consider as courts as
to trial? So very few really. The general consensus is to try and keep these cases out of court, because going to court's really expensive, and if you can resolve the situation beforehand, why spend all that extra money going to trial? So they would go to court more likely than not would be during the liability stage. So we're trying to work out who's done something wrong. So that's, if it is going to court, it usually would be then. If the patient team and the clinicians team are at complete odds at, somebody doing something wrong. And then after that's all been settled, then you go to the quantum stage and then quantifying it. So putting the cost together for how much it's going to be. And that very often would just get settled in a meeting, with the barristers. So they'll negotiate that. So both sides put their costs forward of how much they think it would cost to put this individual back to a position that they would have been were it not for the injury. So say, a child would live independently in the future. So to do that, that's going to be quite costly if they need care and they need a specialist housing and all that. So it's that sort of cost. So then that would be negotiated. So usually that wouldn't go to court, but some do. So probably about 80-90% don't go to trial.
Okay, so that makes it a bit more clearer that, if all the situation goes through and you meet the relevant criteria, this is the kind of outcomes that we see, and sometimes it can be in the millions. So generally speaking, for clinicians who are taken and the case is put against the clinician themselves, you're talking about medical liability cover. How does it work? So is it private insurance?
So as an independent physiotherapist, any physiotherapist, generally you're a member of the Chartered Society of Physiotherapy. As part of that membership, I get insurance. So my insurance through them covers me for about £10 million. So if you're doing high risk activities such as thoracic acupuncture, their insurance doesn't cover you for that. So you'd have to get additional insurance on top of that to cover. So most definitely physios have their own insurance. This is more important if you're working independently rather than under the umbrella of a trust.
Fine. And from your perspective, you would definitely recommend everyone get private cover?
Yeah.
No matter what setting you're working in?
Yeah, I would say so. I mean, obviously it depends what your role is, and there's risks associated with roles. But certainly nurses, physios, we all have insurance generally as part of our registration.
Okay, brilliant. So my next question is really about, protocols and clinical judgment. So we see a lot, NHS has moved a bit more towards a protocolized system where a lot of conditions are actually, into A, B, and C in this order at this time to treat the patient. Sometimes as clinicians, you get like a hunch. You have a certain bad or good feeling about something, and you want to do something that's against what the prescribed, maybe even the guidelines are or the protocols. How do you stand when you're in that situation? Are you safer to go with protocols, and how much can you argue for yourself if you were to say, no, actually here I followed my clinical judgment that, this was safe or this wasn't safe? And
that's a bit of a minefield, and it really depends on the situation. Guidelines are guidance, so there's more flexibility with guidelines. Protocols often can be based on NICE guidelines, so hospital protocols. And your hospital protocol, the protocol in your hospital may differ to a protocol in a different hospital for management of a condition. So the problem with protocols, it takes away the need for professional autonomy.
Yeah.
So it reduces the need for clinical decision-making, analysis of what's going on. So that's the downside of them. Obviously, they're in place to protect patient users and to make things a bit easier. I would say there is, obviously, it's difficult if you are just going to go wild and just do your own thing because you don't like the protocol. If it's a standard protocol that's used all the time and you don't think it works, or it's not logical, or it's not reasonable, then I think you've got a duty to bring that up in your trust and say, I don't think, or evidence has changed, practices have changed, this is a bit outdated, we could do this better, let's look at that. I think that's probably the best approach. There is an instance where a midwife was sued. It's an Irish legal case, so it's not in the UK, it's the England and Wales system that we use here in England. But it's quite interesting to read that. So it pertained to a lady that went into labour. She was having twins. She went into an Irish hospital and they just monitored the heart rate of one of the twins, because the protocol or the general practice in that hospital was you only monitored one heart rate, because the other one, sort of the heart rate of that baby sort of by proxy gave you the heart rate of the other one. And when the babies were born, one was born with profound brain injury and the other one was born, wasn't alive when it was born. And the hospital was sued that although she did follow practice protocol in the area, the protocol wasn't logical, it wasn't reasonable. So she didn't use her clinical judgment there. So you need to, yes, they're there to help, but they're not necessarily definitive. But equally saying that, don't just fly in the eyes of the protocol because you want to do something different. It's a fine line. So if it's something that's not life-threatening and it's a common protocol, I think if you're thinking that's not right, things need to be done differently, then that's the time for that open conversation. I think if it's an emergency situation and there's a true clinical reason why something different should be done, and ideally if somebody else in your department agrees with you, then I think if you decide to do that, then you need to document why you did it. So you need to be very clear why you deviated from the protocol. But things like post-op protocols, say plastic surgery has a lot of protocols, they're there for a reason. So they're very strict on what you can do. It's like tendon repairs, very strict on what you can do. So you wouldn't really deviate that without discussing with a consultant, really. Usually the consultant-led protocols. So it's a bit of, they're there for your protection, but they may hinder you. So you still need to use your autonomous skills, your clinical judgment, your clinical reasoning, but don't necessarily fly in the face of protocol.
So that's really insightful about that case in Ireland where, despite following protocols, it was found that the protocol itself was deficient and wasn't able to accurately reflect the clinical need of the patient. And despite following the protocol, that the midwife was involved in a legal case.
And I think that's why the importance of being up to date, knowing the NICE guidelines, knowing the research out there and looking up protocols you've got and constantly evaluating your clinical practice. Exactly.
And that's why it's so important for continued professional development.
Yeah, absolutely.
And so a little bit of different topic now, if that's okay. So we can talk about, often in these situations where there's a disagreement. So on one side, you've got potentially the patient or the patient's family. On the other side, you have the clinician, whether it's the physio, doctor, nurse, whoever it may be. And, one party is saying, oh, this is the story, this is what happened. And you've got the patient's side saying, no, actually, these are the results of. Which side's, I suppose, word is weighted heavily, or is that a concept that's in legal terms?
So it depends on the situation. Obviously, these legal cases may come up quite a while after the event. So people forget, people's judgment changes, emotion takes over with a lot of things. So there can be a variation in events. So you can get two different versions of what happened. If the medical notes are written well, if they're clear, they're concise, there's no reason to presume that they're not correct, that they were written contemporaneously, they were written by the person that provided the treatment, then probably, unless the patient gives you very good evidence to say otherwise, then probably you'd go with the medical records because that's what you're faced with. There was a case of Sinclair versus Lancaster hospitals where the Mr. and Mrs. Sinclair had a very different experience of what happened to what was documented in the medical records, and the courts actually ruled in their favour because they basically said it made more sense what they were saying. The medical records were very short, they didn't appear to be written by the same person that provided the treatment, and there was a bit of uncertainty about where they were written and when they were written. So the judge decided that the husband and wife version of events made more sense. So it can come down either way. But if you write good records, they're contemporaneous, they're very clear, they're concise, then that really is.
And I think, that's a running theme throughout today's talk, that yes, writing these notes, making sure, in the modern era, we've got electronic patient records, they're even time-stamped as well. So that ensures that, this is the time and this is definitely what was going on at that time. I just wanted to touch on one legal case, if that's okay. And this was, I'm sure you're aware of, Toombs versus Mitchell.
Yes.
It's quite a famous case, and it was one where there was advice about folic acid, and this led to the GP perhaps deciding that yes, the advice was given, the patient's family, patient themselves saying that that advice wasn't given, and the patient themselves were actually born with some genetic abnormalities and deficiencies. So, can you tell me a little bit more about this case and what kind of elements pivoted it towards the patient side, leading to them winning the case?
Yep. So Toombs versus Mitchell is a wrongful life case. It's a landmark case in the UK. Wrongful life cases have never really been over successful in the UK or internationally, because by them being successful, we're accepting that the individual's life is not really worth living and they'd be better off if they hadn't been born. So obviously there's a lot of issues that arise as a result of that. So this case, like you say, the parent went for advice on conception. There was no evidence in the medical records of being told that she needed to take folic acid. So the child was conceived, had a spinal defect, and the case was, mom said, well, if you'd have told me that I needed to take folic acid, we wouldn't have tried to conceive for this child then. We'd have taken the folic acid, we would have waited, and a child with a different genetic makeup would have been born. So a different child completely would have been born. Odds are they wouldn't have had a spinal defect. And the crux of the matter is that the GP said, well, I would have, because it's standard practice, you would say that you need to take folic acid. Mom said, no, but you didn't. There was no evidence in the medical records to say that had been done. So the court decided that mom's version of events seemed to be the most plausible.
Okay, and that went forward with the...
Yes, so that was a successful case and went forward and concluded, so quite a significant case.
So, it just reiterates again on the side where we've mentioned throughout about clear documentation. Yep. And we have these days, we can send sort of e-leaflets, on the patient's notes. Like you mentioned, a lot of notes are quite sparse, not very detailed, and seem to have been rushed. So just taking that extra minute or two can really save you going down the line.
And it would be a minute maximum, wouldn't it? Even if you just typed given folic acid advice leaflet. And I think a key to a lot of these things, particularly in GP practice, maybe to have the leaflets available, either electronically or physically. So you've got them, so they're all up to date and you can just hand it out. And then all you have to document is given leaflet, 1 or whatever you're labelling it as.
So you've mentioned a few times during the course of this podcast about being an expert witness. Now, there are a lot of experienced clinicians working within the NHS in a variety of different roles. What differentiates them and someone who's then relied on as an expert witness?
So an expert witness is somebody that's got a lot of experience and is expert in a particular field. So I'm an expert particularly in paediatric physiotherapy. I do some pain management, that sort of stuff as well. So you've got adequate training to make your opinion valid in a legal case. You then need to obviously make that transition into the legal sector, to working in the legal sector, and generally people might do some specific training regarding how to write expert reports, how to provide your expert opinion, training to give evidence in court. There's lots of ongoing training, but fundamentally it's somebody that's got a lot of experience and an expert in a particular area. So somebody that big clinically, if you're in hospital, you generally recognise them as an expert in their field.
Fine. So someone with a lot of experience has had some kind of training, either qualification in the legal area, and can provide that ability for when they can provide their insights on a case and perhaps comment on what went well, what could have been improved, etc. Okay, brilliant. So I'm going to ask you quite a tough question now in terms of one of the most topical issues within the NHS at the moment, and that's around the physician associates, whereas they're being renamed as the physician assistants. At the moment, there's an uncertainty of doubt about who's going to be the overarching regulator, who's going to be responsible for these group of clinicians working within the NHS, and if something were to go wrong, who's going to be responsible. Can you shed some light on what your opinions are on this matter as an outsider, someone who's worked in these kind of legal cases in the past, and that can provide some insight into this potentially?
Yeah. I do think there's a lot of unknown, and I think that's the problem. These roles have been put together. People have done the course, but obviously they've got very different backgrounds behind them. So it's not like, say, a physio or a nurse are very experienced and then do some advanced practitioner course. So they've got all that background knowledge, skills, and then go on to do this higher level training. So it's very different from that. Regulation is an issue. I think, again, going back to physios, nurses, doctors, we've got regulatory bodies that manage the sort of expectations, the regulations around what training you need, what levels you need to perform at. As far as I'm aware, that's not really available across the board. I think there's some degree it is, but it's not mandatory, is it? Exactly.
I mean, at the moment, the GMC were mandated to take over the regulation for PAs, but even at that we're still in the voluntary sort of period. They call it the transition period I think there's still about some months left on that. And not everyone has sort of joined the register either. So there is some grey area in this sector.
Of who's regulated and who's not. And I think that the nature of the role is very different in every clinical area. So I think that adds another level of complexity because it's not a standard role as such. Not all will do the same thing.
Exactly.
And I think if, for example, there was an issue with a GP, so a GP was sued, then the expert witness that would come in to review what was done, how it was done, the records, would be a senior expert witness that's a GP. So they've got a working knowledge of that area. So usually there's somebody that's a lot of experience. Now with these new roles, we've not got that level of experience, and we've not got that level of seniority above them that it could look. And even if there was somebody more senior, it doesn't necessarily mean that their role is the same as the role of another PA. So I think there's a lot more work that needs to be done. I think there's a lot of uncertainty around that role, and I think it does potentially leave it a little bit vulnerable for litigation.
Yeah, I think the factors you've mentioned, the fact that it is such a new role within the NHS, and there's relatively few PAs within the NHS, around 5,000 or so. So that itself as such a small cohort, naturally that leaves very few sort of expert witnesses if a situation were to occur with a PA. And over really supervising, there is supposed to be a doctor supervising, but to be a key witness, ideally they'd be in the same profession to see, this is how I would have reacted to these circumstances. This is how I would have documented. And that PA profession does lack that at the minute.
It doesn't have it. So I think it's an area of quite a lot of vulnerability, definitely at the minute.
I think it's important to be open and honest about these kind of things. And, we'll see what the government kind of, with the Leng review and these kind of works in progress. We'll see what kind of things.
And it is changing, isn't it? They've changed the title to make it more transparent to patients what the role actually is. So I think it will get there. I think there just needs to be a push to get there as soon as possible, really.
Okay, brilliant. So thank you very much for sharing your time with us today. I know the audience and even myself got a lot of insight into the world of litigation, legal cases you mentioned, and some advice about note-taking and documentation as well. So that's really, really important if you work in the modern NHS and I suppose in any healthcare system. So in terms of yourself, I think it would really benefit some of the viewers if they were perhaps thinking about taking a similar journey to yourself. So if you can explain, from becoming a physiotherapist and then developing yourself, and in each moment, what kind of things, were allowing you to open the door for the next stage, that would really help our audience.
Okay, so I qualified quite a long time ago, and when I qualified, it was standard practice that people are going to a basic grade rotation, so like band 5 rotation. So I did that, so you get a good grounding on all the different areas, and then my career I progressed, so senior 2, which would probably be a band 6 now, so it was more specialist area, so that was in orthopedics, and then I got a band 7, then a clinical specialist role within pediatric orthopedics. So it was highly specialised. So I did highly specialised work in a big national centre. I then did some international training, some international teaching. So we did a lot of training. Somebody actually recommended that I should go into medical negligence because they said, oh, you'd be really good at writing that sort of report and giving your opinion. Yeah. So I just sort of fell into it from that point of view. And then I progressed what I did. But that took a long time. I mean, it's taken 12 years. It does take a good few years to get established because the value of a good expert witness can add a lot of money to a claim. So it's hard for people to take risks on people they don't know, people are less experienced. So I just worked. I did lots and lots of work, lots and lots of training, loads of courses, and then I did a master's in medical law and ethics. So that just gave me a broader knowledge of how the law works. So, and that's where I am today.
Oh, very good. So thank you for taking time, Tracy, today to share your experience and your valuable insights. And if someone was to want to reach out to you, gain some, knowledge from you or any insights, or even inquire about your services, how would they best do that?
So I can be contactable by email at forgespecialistrehab@gmail.co.uk. I've got my podcast, which is Propping Up the Bar, which people can have a listen to and then comment on there, or people can contact me on LinkedIn.
Perfect. So it's Tracy Fields, is that right? Yeah. Yeah. Tracy Fields on LinkedIn, and she's happy to answer any questions. So once again, a big thank you, and we'll wrap up there. So that sums up today's podcast. I'm sure you've gained a lot of insight into your own clinical practice. I suppose the main takeaway for today is about documentation and protecting yourself. It's very, very important in the modern NHS to write clear documents, clear notes, and ensure that you safety net very well with your patients. We explored some legal cases where that wasn't done and unfortunately resulted in some legal precedents being set. So hopefully we can avoid that and be safe throughout our clinical journey and our careers. And hopefully you took some valuable insights from today. And we'll see you on the next podcast. I've been Camille and this has been Tracy, and we'll see you very soon.